Welcome to a deep dive into hyperthyroidism, a condition that's super important for anyone in medicine, especially for those gearing up for exams like the MCCQE1.
Yeah, it's one of those topics that can seem straightforward, but has so many nuances. And actually, our section hook today really highlights one of those key distinctions.
Right, because did you know that not all high thyroid hormone levels are considered true hyperthyroidism? Some conditions just release pre-made hormones without the gland actually working overtime.
That's a great point. So, what exactly are we talking about when we say hyperthyroidism in its truest sense, then?
Well, it's fundamentally about the excessive production and secretion of thyroid hormones, specifically T3 and T4, by the thyroid gland itself. This ramps up the body's metabolism, leading to a whole cascade of effects.
So, it's when the gland is actually overactive, not just leaking hormones. Got it.
Exactly. And that distinction is crucial because it helps us categorize the causes. We mainly talk about primary hyperthyroidism when the thyroid gland is the culprit.
Okay, so what falls under that primary category? The gland is the problem kind.
The big three there are Graves' disease, toxic multinodular goiter, and toxic adenoma. These are where the thyroid is genuinely cranking out too much hormone.
And then there are those other scenarios you mentioned, where it's not truly primary hyperthyroidism, but still presents with high thyroid hormone levels?
Precisely. Those are often grouped under other causes of thyrotoxicosis. Think of conditions like various forms of thyroiditis, where inflammation causes a temporary release of preformed hormones, or even exogenous thyroid hormone intake, like someone taking too much medication.
So the difference is whether the thyroid gland is actively making too much, or if it's just releasing what's already there, or if it's coming from outside the body.
That's the core of it. And speaking of primary hyperthyroidism, we really have to spotlight Graves' disease because it is by far the most common cause.
Right, I remember that. It accounts for a huge percentage of cases, doesn't it?
Absolutely. It's responsible for about 60 to 80% of all hyperthyroidism cases. It's an autoimmune disorder where antibodies, specifically thyroid-stimulating immunoglobulins, or TSI, mistakenly activate the TSH receptor on the thyroid cells.
So these rogue antibodies are essentially tricking the thyroid into overproducing hormones. That's fascinating and explains why it's such a persistent issue.
Exactly, and clinically, it's often characterized by a diffuse symmetric goiter, which is that enlarged thyroid gland. But what really sets Graves apart are the characteristic extrathyroidal manifestations.
Oh, you mean like the eye symptoms, the ophthalmopathy, and that skin condition?
You got it. Proptosis, lid lag, diplopia, and sometimes even pretibial myxedema. These are strong clues pointing to Graves' disease and help differentiate it from other causes of primary hypothyroidism, like toxic multinodular goiter or a toxic adenoma.
That makes sense. So understanding that distinction between true hyperthyroidism and thyrotoxicosis, and then knowing the major players like Graves within the primary group, really sets us up to tackle the complexities of diagnosis and management. It's truly setting the stage for diverse presentations and etiologies.
Now, let's paint a clear picture of what hyperthyroidism actually looks like in a patient, because we've talked about the causes, but what are the actual red flags someone might experience?
Right, exactly. It's all about that hypermetabolic state the body's in. So you're often looking at a racing heart, palpitations, and definitely weight loss, even if they're eating a ton. Isn't that fascinating?
That's a great point. So almost like their body is running on overdrive. And heat intolerance sounds uncomfortable too, like always feeling warm?
Absolutely. Heat intolerance is a big one, along with excessive sweating. On the neurological side, anxiety, irritability, nervousness, and insomnia are common, and a fine resting tremor is classic.
So all these things are really pointing to an overactive system. What about gastrointestinal symptoms?
Yeah, increased bowel movements or even diarrhea can occur. It's truly a systemic effect affecting multiple organ systems, from cardiovascular to musculoskeletal with muscle weakness.
Okay, so those are the common systemic symptoms that could point to it. But wait, there's more. What about those really specific, almost unmistakable signs, especially for Graves' disease?
Ah, the telltale signs. For Graves' disease, we often see ophthalmopathy. This includes exophthalmos or proptosis, where the eyes seem to bulge forward, and periorbital edema.
That's the bulging eyes, right? And what about lid lag? I've heard that term.
Exactly. Lid lag or von Graefe sign is where the upper eyelid lags behind the eyeball when someone looks downwards, giving a staring appearance. Then there's pretibial myxedema, a localized dermopathy typically on the shins, which is rare but highly characteristic.
Wow, so those are some really distinct visual cues that can help with diagnosis. But does it always present so clearly, or can it be subtle sometimes?
That's a really important question. Presentation can vary significantly based on age, the specific etiology, and how severe the condition is. For example, in older individuals, symptoms can be much more subtle.
So it's not always the textbook picture, especially in the elderly. What's happening there?
They might present with just fatigue, weight loss, or atrial fibrillation without the overt anxiety or obvious heat intolerance. It makes the diagnostic puzzle even more challenging in that population. We really need to have a high index of suspicion.
Right, because if you're not looking for it, you might miss it, especially with those less obvious symptoms. So recognizing these variations is key.
Precisely. It really underscores why understanding these presentations, both common and specific, is critical for making a correct diagnosis. The clues are there if you know where to look.
So we've talked about all the different ways hyperthyroidism can show up, but how do we precisely confirm the diagnosis and, crucially, pinpoint the underlying cause?
That's the million-dollar question for the MCCQE1, isn't it? The most sensitive initial test, the one you always start with, is the thyroid stimulating hormone, or TSH.
Right, exactly. And in cases of primary hyperthyroidism, where the thyroid gland itself is overproducing, what's happening with that TSH level?
It'll be low, often suppressed. A suppressed TSH is your primary clue that the thyroid gland is cranking out too much hormone, signaling the pituitary to back off its stimulation.
Okay, so low TSH points us in the right direction. What's the next step to confirm that biochemical diagnosis?
You'd follow up with free thyroxine, or free T4, and sometimes free triiodothyronine, free T3. If these are elevated along with that suppressed TSH, you've confirmed hyperthyroidism.
So, what is the most appropriate initial investigation? Would be TSH, then free T4/T3 to confirm. But what if someone has isolated T3 toxicosis?
Good point. That's when you'd see elevated T3 with a normal T4 and still a suppressed TSH. It's more common in early Graves or toxic multinodular goiter.
But confirming hyperthyroidism biochemically is just one part, isn't it? The real challenge is finding out why the thyroid is overactive.
Absolutely, and this leads us to what is arguably the most crucial test to differentiate the causes, the radioactive iodine uptake, or RAIU, and scan.
Ah, the RAIU scan. So, how do we interpret the results of that test to figure out the etiology?
It's all about uptake. If you see high uptake that's diffuse and symmetric across the whole gland, that's characteristic of Graves' disease. The antibodies are stimulating the entire gland. But if it's high uptake that's nodular or patchy, showing hot nodules with suppressed uptake elsewhere, what is the most likely diagnosis?
That would point to autonomously functioning nodules like in a toxic multinodular goiter or a toxic adenoma. The nodules are doing all the work.
Exactly. Now, for the flip side, what if the RAIU shows low uptake, minimal to no uptake at all?
Low uptake tells us it's not increased synthesis, but rather release of preformed hormone. So we're thinking thyroiditis, whether subacute, painless, or even drug-induced, or quite simply, exogenous thyroid hormone intake.
That's a key distinction. The RAIU scan moves you from they have hyperthyroidism to this is why they have hyperthyroidism, helping us in pinpointing the exact cause with confidence.
Once diagnosed, what's our immediate next step in management to get things under control?
Well, the very first thing is often about symptom relief, right? Patients come in feeling miserable with palpitations, tremors, and anxiety. So, what is the first line treatment for these acute symptoms?
That would be beta blockers like propranolol or atenolol. They work wonders for rapidly controlling those unpleasant symptoms like tachycardia and the fine tremor, bringing immediate comfort to the patient.
Exactly. They hit those heightened sympathetic nervous system responses straight away. And propranolol even has that cool extra benefit of inhibiting the peripheral conversion of T4 to T3, which means it helps reduce the active hormone levels a little bit too, beyond just symptoms.
That's great for the immediate relief, but it doesn't really address the underlying problem of the thyroid gland overproducing hormones, does it?
You're absolutely right. For that, we need anti-thyroid drugs, or ATDs, to actually block the hormone synthesis. So what is the preferred anti-thyroid drug in most general situations?
That would typically be methimazole, or MMI. It's generally favored because of its convenient once-daily dosing, which really helps with patient adherence, and it usually has a lower incidence of serious side effects compared to PTU, its counterpart.
Right. MMI is definitely the preferred choice for most patients. But this is where it gets really interesting because we have those two very specific scenarios you hinted at in our hook, where propylthiouracil, or PTU, becomes the essential and preferred option.
So, when would a clinician absolutely pivot to PTU, despite MMI being the usual go-to?
The first major scenario is during the first trimester of pregnancy. It's a critical time, and MMI carries a higher risk of birth defects during those initial weeks. So, for fetal safety, PTU is the safer alternative to manage the mother's hyperthyroidism.
That's such a crucial detail for patient safety. So, PTU for the first trimester, then maybe switch back to MMI later in pregnancy if needed as per the source material? What's the other high-stakes situation where PTU is indispensable?
The other one is in the management of Thyroid Storm, which, as we know, is a life-threatening medical emergency. What makes PTU superior here?
Well, in a thyroid storm, you need everything working quickly. PTU is preferred not just because it blocks new hormone synthesis, but critically, it also inhibits the peripheral conversion of T4 to Th3. That means it reduces the levels of the most potent thyroid hormone already circulating, providing a faster and more comprehensive reduction in thyroid activity.
That dual action is key during a crisis. It's fascinating how a drug that's generally considered second line becomes the absolute first line in specific critical contexts. It really underscores the importance of understanding the nuances of each medication.
It certainly does. It's all about weighing those crucial considerations for medication choices, ensuring patient safety, and adapting the treatment strategy to the specific clinical situation at hand. Beyond daily pills, what are our long-term options for managing hyperthyroidism, especially when antithyroid drugs might not be suitable or effective?
That's a great point. When we think long-term, two definitive treatments come to mind: radioactive iodine therapy and surgery, or thyroidectomy.
So let's start with radioactive iodine, or RAI therapy. What exactly does it entail, and when is it typically recommended?
RAI therapy uses oral I-131, which the thyroid's follicular cells absorb. It then emits localized radiation that destroys these overactive cells, reducing hormone production. It's a definitive treatment for Graves' disease, toxic multinodular goiter, and toxic adenoma.
So it essentially targets and shuts down the overproducing parts of the thyroid. What's the typical outcome then after RAI therapy?
Precisely. The usual outcome is permanent hypothyroidism, meaning patients will then need lifelong thyroid hormone replacement with levothyroxine. It's often preferred for older patients or those who can't tolerate ATDs.
That makes sense, but it sounds like a powerful treatment. Are there any situations where AIR is absolutely contraindicated, like do not even think about it situations?
Absolutely. The major contraindications are pregnancy and breastfeeding due to the radiation exposure risk to the fetus or infant. Another key one is severe active Graves' ophthalmopathy, as AIR can actually worsen the eye condition, although sometimes corticosteroids can mitigate that risk.
Wow, that's crucial to know, especially for patient counseling. So if AIR isn't an option or isn't preferred, what about surgical removal of the thyroid gland, the thyroidectomy?
Thyroidectomy is another definitive option. It involves removing part or all of the thyroid. This might be indicated for a large goiter causing compressive symptoms like difficulty breathing or swallowing, or if there's suspicion of malignancy.
And I imagine if medical therapy has failed, or if a patient simply prefers a surgical solution, it would also be considered.
Exactly. Or even in severe Graves' ophthalmopathy or pregnancy when ATDs aren't tolerated. Now, a critical point for the MCCQE1 and in practice is the preoperative preparation for thyroidectomy.
Right, I remember hearing about that. You can't just jump into surgery, can you?
No way! Patients must be euthyroid before surgery, usually achieved with antithyroid drugs. Then a crucial step for 10 to 14 days pre-op is administering iodine, like Lugol's solution.
Wait, really? Iodine before surgery for hyperthyroidism? Isn't iodine typically associated with thyroid function?
It sounds counterintuitive, but it's given after ATDs to reduce the gland's vascularity and minimize the risk of bleeding during the procedure. It's a vital step to ensure a safer surgery.
That's a really important detail. So to recap, definitive treatments like RAI and thyroidectomy offer long-term solutions, but each has specific indications, contraindications, and very important preparatory steps.
Yes, and understanding these nuances is essential for both managing patients and tackling those exam questions about optimal long-term management strategies.
It truly is. Knowing when to choose which option and what to do before is key to planning for a life free from hyperthyroidism's grip. Finally, let's tackle the highest stakes situations, managing hyperthyroidism during pregnancy and confronting the life-threatening thyroid storm.
These are definitely critical scenarios where the management approach shifts significantly. What's the protocol for pregnant patients?
Well, it's a careful balancing act. In the first trimester, propylthiouracil, or PTU, is the antithyroid drug of choice due to its lower teratogenicity risk compared to methimazole.
Ah, so PTU first, then a switch. That's a good distinction to remember for the exams.
Exactly. Then in the second and third trimesters, you'd switch to methimazole or MMI. The goal is always to keep the free T4 levels in the high normal range, minimizing fetal exposure.
And what about other treatments for hyperthyroidism in pregnancy? Are radioactive iodine therapy or surgery options?
Definitely not. Both radioactive iodine therapy and surgery are strictly contraindicated during pregnancy because of the significant risks to the fetus. This makes the careful use of ATDs even more critical.
That makes total sense. Now let's dive into the thyroid storm. Just the name sounds incredibly serious. What exactly defines this emergency?
Thyroid storm is a severe, life-threatening exacerbation of hyperthyroidism. You'd see a patient with incredibly high fever, profound tachycardia, often with atrial fibrillation, and a markedly altered mental status.
Wow, that sounds intense. What other symptoms would stand out?
You'd also see significant GI dysfunction, like vomiting and diarrhea, and signs of heart failure. It's truly a hypermetabolic crisis affecting multiple organ systems.
So, given how rapidly severe it is, the treatment must be aggressive and multimodal. What's the immediate sequence of interventions?
That's where our hook comes in. You might think iodine first to block hormone release, right? But the absolute first step, along with symptom control using IV beta blockers like propranolol, is to give an antithyroid drug.
And for thyroid storm, that would be PTU because of its added benefit of inhibiting peripheral T4 to T3 conversion, correct?
Precisely. You give PTU orally or via NG tube. The crucial point is that you must administer PTU at least an hour before you give iodine, like Lugol solution or SSKI.
Ah, so PTU first to block new hormone synthesis, then iodine to block the release of preformed hormone. Otherwise, giving iodine first could actually worsen the storm by releasing more hormones.
Exactly, it's a high-yield detail. Additionally, corticosteroids like IV hydrocortisone are given to decrease peripheral T4 to T3 conversion and provide adrenal support.
And, of course, aggressive supportive care like cooling and fluid resuscitation would be paramount.
Absolutely. Managing these special cases requires not just knowing the drugs, but the precise order and rationale behind their administration.
It really highlights how nuanced and critical medical knowledge needs to be, especially for the MCCE QE1.
It certainly does. Mastering critical knowledge for exam success and patient safety is key here.